very interesting situation, which is actually relatively common, I would say. And that is this appearance here at the GOJ, gastroesophageal junction, and it's been through multiple gastroscopies by colleagues in other hospitals. Some biopsies have shown regeneration, some biopsies, one biopsy has shown not sure about low-grade dysplasia. It's a pretty common scenario. The patient has, if we just look where the top of the gastric fold, he has a hiatus hernia for sure. You can see it here. You can see camera erosions on the lip of the hiatus hernia as it moves across the diaphragm below here. And then this is the lower esophageal sphincter, I think. And at this point, there is significant inflammation, clearly. And the question is this more than inflammation, or is this just inflammation? And what about the relevance at all of the biopsy showing low-grade dysplasia before? So, okay, the first thing is that the patient has a significant hernia, and this is almost certainly the cause of the inflammation at this zone. The next thing is, okay, what are the endoscopic features that differentiate inflammation from potential malignancy? And let's go through them step by step. So the first thing is a overview assessment, which you should always make. I had this view at the start of this procedure, paused. Let's do it again. So this is containing certainly surface fibrin, contact bleeding. It's containing ulcers, definitely. There's one up in the 2 o'clock of the image here, and we can just go more towards it up there. It's also clear that there is a small component of the kind of proximal extension, cranial extension of the gastric mucosa here, in at least 2 of those 3 triangular-shaped lesions that are coming more north. And then the other question is, of course, is there other inflammation around in the esophagus? Well, yeah, it's kind of circumferential. There's also evidence here of Cameron lesions. Is there evidence of inflammation elsewhere in the stomach or duodenum? Well, there's this ulcer here in the stomach, and what that is and how relevant that is. There's a little bit potentially of, but not terrible. There's certainly not much evidence of atrophy, and in the duodenum, we don't see much evidence of inflammation. So, back to the question. For you, Andrea, looking at this, what are the components of this? And we didn't use virtual chromoendoscopy at all yet. What are the components of this that suggest that this is probably inflammation, not malignancy?
So there are, first of all, inflammation is something that really makes the endoscopic characterization, also the pathological assessment, much more difficult, especially for low-grade dysplasia. So if there is a cancer, an over cancer, you would see a demarcated area with an irregular surface and vessel.
Let's pause on those 2 things. I think both what you said is important. So, I mean, with the devil's advocate in mind, you could argue that there are multiple demarcated areas within this. What is, obviously that's not what you meant. What did you mean by demarcated area?
Well, I mean an area with a clear change in the regularity of the pattern, like compared to the background.
Okay.
Of the vessel mainly, and yeah, indeed, in the context of inflammation, might be very, very difficult. But apart from the ulcers, the rest of the mucosa, you see elongated crypts, which are indeed typical of inflammation, and also some irregularity of the vessels, but it's somehow something generalized. Personally, I don't see a clear demarcated area, so this, for me at least, is more suggestive of just inflammation, and I think another control endoscopy with biopsies should be done.
Okay, well, we skipped the management. Yeah. So let's just stick on this image. I think is useful, right? Because this is a virtual chromoendoscopy image highlighting the blood vessel pattern. In this image, there are multiple morphologies. What you said about a demarcated area, I agree with. I think the critical thing about a demarcated area is that there is a regular to irregular pattern. Like one of the areas contains an irregular pattern, one contains a regular pattern. For me here, I don't see any irregular patterns. You said that, I think. So no demarcated area, but 3 morphologies at least on here. In the 6 o'clock, we see the standard inflamed gastric mucosa, I think. In the center, we see neosquamous formation within an area of regeneration, where the light reflection is. And then above that, we see squamous mucosa, I think. We see IPCL pattern. We see the IPCL pattern that is standard associated with inflammation. That is that they are enlarged, a little bit more tortuous, but that they are not making bridges and that they are not extremely tortuous like they might be in squamous dysplasia or squamous cancer. So actually what you said, let's break it down and bring it right back to what you said originally. I don't see anything irregular here. That's the key. The key is that there is nothing irregular in this image. Now let's just flip around and go to the rest. Of course, we have high quality imaging here, but let's take another example image. So here's another zone of this, and let's just make it maybe a little bit more clear.
Yeah, if you see a pattern like that, of course, in the mid-proximal esophagus without inflammation, this is something a little bit different, because indeed inflammation and low-grade dysplasia in the squamous mucosa might look quite similar.
Very important. But if you see this at the gastroesophageal junction, in an area of clear inflammation with some ulcers, then this is pretty typical, I would say, for inflammation. So here we have a image with the squamous background above the area of inflammation, and again, just abutting the inflammation, you can see the transition between pretty normal IPCLs in the top of the image down into quite dilated but not irregular IPCL. So this is another marker of inflammation. Let's see if we can see something else. This is pretty standard, I would say, transition between the esophagus and the stomach. What about here?
Yeah, I think standard. Also the shape, like the surface is, indeed a little bit uneven, but it's not like there is no clear bulging or sessile component. Of course, this might be or might be not present all the time, but this is something also to take into account.
You mean as versus cancer, that in a cancer you might expect there to be a bulging component,
indeed.
and there's not.
Or a very depressed area outside of the ulcerated
So this is
zone.
a depressed area, right? At the bottom there is gastric mucosa, at the top there is probably Barrett's mucosa, maybe. And in the middle there is this depressed zone without very much vascular pattern at all. This is either regeneration or a bit of ulceration, right? But again, the difference between that and malignancy, it can be very difficult when you're starting out. I mean, this as well, here is an island of Barrett's mucosa, probably at the top of what is a healing ulcer. You can see the Barrett's mucosa is entirely regular, and you absolutely do not see a totally irregular glandular pattern within this area in the depression, because if you did, a Barrett's cancer can look very like this. Very like this. Just the part in the middle is very irregular, and here we don't see that. So you already hinted at the management of this, but I think the management of this is maximize the acid suppression, which is obviously not happening here. There cannot be maximizing the acid suppression, or it's inadequate, so we need to increase the dose, or we need to change the agent. We need to consider the impact of the hiatus hernia on this, and we need to rebiopsy, because I think the key is experienced pathologist, rebiopsy, give the endoscopic opinion that the endoscopic appearances are suggestive of inflammation, and see what comes back. I think that's the key. The communication between the endoscopist and the pathologist here is very, very important, because of course if you say, I think that's cancer, then they are thinking, well, okay, then I better do my special stains and everything else, and I might get to the idea that actually this is cancer. And I mean, in your mind, to you, looking at this image, what is the chance that that's cancer?
I think it's quite low personally, but...
But for you, in your eyes, give a number, percentage chance that's cancer. Maybe put differently, how surprised would you be if that came back as cancer?
Well, I would be pretty surprised. I would say it's around 5%, but even less, I think. And also because I know the patient's history, he's had also CT scan, not showing anything, and so his biopsy was read the second time by another
Well,
pathologist.
let's stick on the just endoscopic image. I mean, I think the chance is very low,
Yeah.
very low. But you need to know what to look for. You need to know how to analyze it, and you need to know, and I think this is a critical thing, how to biopsy. So how do you biopsy in the esophagus? Open it, please. So the way to biopsy the esophagus to get a decent chunk of tissue, and it's not easy at the junction. So it can be very easy to just get a superficial biopsy, which the pathologist really struggles to interpret. So you have to balance the forceps. You have to get an area that you might be interested in, like maybe like this, and you really have to suction it in like this. Use the torque and everything else. Close it, please. So you get a decent piece of tissue. You make sure you're not on a varix when you do it. Take it out. Okay, that's sort of decent sized biopsy that they might be able to interpret. I think people are not 100% sure how to biopsy in the esophagus. You also want to label the clock face orientation. So that is pretty much that biopsy I took probably from about 5 o'clock maybe. Yeah. So we're going to now take clock face orientation biopsies, label them in separate pots. So that if we do get something come out of these biopsies, we're also going to know where it came from. So this biopsy 5 o'clock, and then we're going to go for the rest. We won't bore you with the rest of the biopsies. Thank you very much for watching. Thank you, Andrea. Come back for another one another time. Thanks for watching.